Good morning, everybody. It's a pleasure to invite you all to the third colloquium on health systems and control of neglected diseases in Asia, which is happening in Bangalore. Now, I welcome Dr. Devdasan, the founder and director of the host organization, Institute of Public Health, Bangalore, to address the gathering. Thank you.
Good morning. I think I've already welcomed most of you all yesterday at the inauguration, so I won't take much time, except to say once again, welcome to Bangalore, and I hope you all have a nice time in the next 2 to 3 days. And for those who have come from outside our country, I hope you all will take some time to get outside this hotel and outside Bangalore and see other parts of Karnataka and India, which are very beautiful, and this is a lovely time for tourists to visit India. So I hope you'll take this opportunity to travel and enjoy India. Today, without much further ado, I want to start because already we are running behind time. I just have one small announcement to make. That is, this particular conference, Colloquium, has some innovative communication techniques which are being used, because traditionally we usually have somebody presenting and a few questions and then it is over. But here we have 2 to 3 channels of communication by which the participants can communicate their thoughts, their opinions, their ideas to the entire colloquium. One is through a blog post. If you go to the website, which is colloq2013.in, you will be able to see the colloquium website, and in that, if you click on the blog, you'll see all the blog posts. You can add your comments. You can say, I like this, I didn't like this, I don't agree with so-and-so person, etc. So this starts a kind of dialogue with other scientists also. So that is one way of communicating. The other is through Facebook. So for all of those of you who have Facebook accounts, you can become a member of this particular group. This is a private group, so it's not open to the general public. So we are trying to maintain privacy here. But if you've got a Facebook account, just ask for membership, and Ildiko, who's here, she will make you a member, and then you can post on this. You can comment also on various other people's posts. So that is the third. And then for people like us who are a little old and who are not very tech savvy, there is a notice board outside, and we have put post-its, so you can also write your comments and stick it on the notice board, and we will incorporate this into the discussion. So once again, thank you, and let the show begin. So where's Triveni?
Can I request the chair, co-chair, and the keynote speakers for this session to come on the dais, please? Dr. Ravi Kumar, Professor Shyam Roy, Professor Jacob John, and Professor Suman Rijal, please. I'm happy to invite you all for the session on state of the art of the control of neglected diseases in Asia, which is part 1 session, which is happening now. Part 2 is scheduled for tomorrow morning, which is session 4. This session has 6 presentations, followed by discussion and concluding remarks by the chair and the co-chair. The session is being chaired by Dr. Ravi Kumar, and Professor Shyam Roy will be the co-chair for this session. Keynote address will be delivered by Professor T. Jacob John, and who is from Christian Medical College, Vellore, and Professor Suman Rijal from BP Koirala Institute of Health Sciences, Dharan, Nepal. It's my pleasure to welcome Dr. Ravi Kumar formerly Regional Director of Health and Family Welfare, Central Health Services, Government of India, who is currently working as Chief Medical Officer in the Ministry of Labor and Employment, Government of India. He graduated as medical doctor from Bangalore University and awarded with MPhil from Rajasthan University, India. He has over 24 years of experience working in the field of neglected diseases and in the National Vector-Borne Disease Control Program, Government of India. We cordially welcome you, sir. Thank you for being here. And it's an honor to introduce who is the co-chair for this session, Professor Shamil Roy, Chief Scientist from Indian Institute of Chemical Biology, Kolkata. After awarding with doctorate in biochemistry, he is trained in cellular immunology from Massachusetts Institute of Technology, Cambridge. From 1991 onwards, he is working on leishmaniasis at Indian Institute of Chemical Biology. We welcome you, sir. Now I'll leave the floor to the chair and the co-chair to take the session forward. Thank you.
Good morning, everybody. I hope all of you have had a pleasant evening yesterday and a comfortable sleep. Bangalore has a very pleasant weather at this part of the year. I am sure you have enjoyed the weather by going for a long walk. Since we are already behind schedule, let us start the scientific session. So it's my privilege to introduce Dr. Jacob John. Introducing Dr. Jacob John is very easy. All I have to say is, here is Dr. Jacob John. He is well known to all researchers, scientists in the field of health, especially in the field of vaccines and immunology in India. However, to complete the formalities, I would like to say a few words about Dr. Jacob John. Dr. Jacob John is specialized in pediatric infectious diseases and combined clinical work with diagnostic virology, research, community-level disease epidemiology, vaccinology, and control of infectious diseases. The major part of his teaching and research career was in the prestigious Christian Medical College, Vellore. Now he has been elected to the fellowship of all Science Academies of India and of 2 Royal Colleges in UK. In 1994, he was elected the president of the Indian Association of Medical Microbiologists, and in 1999 as the president of Indian Academy of Pediatrics. He was the main force guiding the global polio eradication initiative to accept the inactivated poliovirus vaccine, IPV, in order to complete and conclude eradication. Consequently, in 2015, the entire world will begin using IPV. After retiring from CMC Vellore, he has continued to teach vaccinology and conduct research on polio vaccines and an encephalitis-like disease due to plant poisoning. Dr. John has published more than 500 scientific papers in Indian and international journals. He is currently the chair of the Child Health Foundation, New Delhi, member of the Strategic Advisory Group of Experts on Immunization, Working Group on Global Polio Eradication Program at Geneva, member of Technical Advisory Group on Immunization, WHO Southeast Asia region, member of the Technical Advisory Group on Eradication of Polio in the Eastern Mediterranean region, and the president of Rotary Club of Vellore Tuberculosis Control Society. I can go on, but I request Dr. John to take over, please.
It's a pleasure to be in the garden city of India, Bangalore, and particularly to this international or bilateral colloquium on 2 areas of my particular interest: health management system and neglected infectious diseases. Now, no 2 countries have the same health management system. And India will illustrate that when you learn something about the health management system in India. Neglected infectious diseases have been defined by different people differently, and global public health community will define it from a global angle. Health researchers would define it from the neglected research viewpoint. Pharmaceutical companies neglect drugs and vaccines, so there are ways of defining them. So let me define these terms for this session. Health management system should consist of two components: public health, which is by definition in public sector, and healthcare, which could be in public sector and private sector, like in most of the world except perhaps two countries, or one country actually, Cuba. Disease control is a public health term, an epidemiological term, meant to reduce the incidence of disease or infection to a predefined level. And it's very important that you have to define to what level you want control achieved, and to document that the decrease in incidence was not merely a secular trend, as it happened with many diseases, particularly tuberculosis in the 19th century, but it is through intervention. I define neglected diseases for this occasion as the health management system, particularly in India, has no intention to control a certain number of diseases. We are familiar with the term medical negligence. That is, if you flout the norms of diagnosis or treatment, it's medical negligence. So let me introduce a concept of public health negligence. Failing to control due to flouting norms of economics, epidemiology, or ethics in public health, and therefore you are not achieving the goal that you set when you said you would control the non-neglected diseases. There are two modes with one goal: keep people healthy. Public health and healthcare. Both of these were contributions of the scientific or Western or modern medical system, in which public health actually grew earlier than healthcare, scientifically based healthcare in the West. Public health acts on the community and on the environment, and their principle is equity. Healthcare acts on individuals one by one, and the principle is fairness. There are a lot of sharing of the information system, diagnostics, actions, tools, intervention, ideas, all shared by both. But because of that sharing, a lot of people in India missed the elephant, the public health, in the room. So to summarize, public health focuses on community, monitors all diseases. You cannot say public health will look at some diseases and will not. There is no room for public health to neglect diseases. Social justice, I mentioned equity. It's an infrastructure, an invisible infrastructure for the development of the nation, and federal and state cadre and career path are essential. Healthcare, on the other hand, focuses on individual. If you're sick and you go to a medical system, you diagnose and treat, and at best you give preventive treatment for those at risk, and the system, the fairness comes out of the market justice issues. Of course, public and private sectors can play, and in countries with good public health, the private sector healthcare is actually supervised and quality controlled by that. It's actually a service, unlike public health, which is an infrastructure. The structural elements of public health should be a formal department, which, of course, we all know that not established in India, a hierarchy of trained officers, cadre structure, functional unit in every district and town, lab support service, which is pyramidal, communication system channels, reports and publications, regular bulletins, training institutions. The functional elements of public health should be disease control, should be the purpose. So continuous public health surveillance, which is absent in India. We have fragmentary systems of surveillance, more than 3 that I can think of, but they don't function in an integrated public health surveillance system. Monitoring of environmental risk factors and mitigating risk factors in the community and environment is the main function. Of course, health education for behavior modification, information feedback, early detection of outbreaks, investigations and control of all endemic diseases by intervention. So when we talk about infectious diseases, the human mastery over pathogens are usually presented as 5 levels. Control I have already defined. Elimination is reducing the incidence of disease or infection, as the case may be, to 0 and sustain in a defined population. Elimination of infection is different from elimination of disease, and you can target whether you want to eliminate the disease while infection continues, or elimination of infection is also part of your goal. I will not spend time on those who are familiar with these ideas. Eradication is when you reduce infection incidence to 0 globally, and intervention may not any longer be necessary, but in some cases it will be necessary for various reasons. Polio, for example. We have successfully eradicated smallpox using vaccination, successfully eradicated rinderpest or cattle plague using vaccination, a veterinary disease of significant economic impact, and we are on to eradicating polio, guinea worm, and a few diseases coming behind it. Extinction is when pathogen is made to become no longer present either in the freezers of laboratories or in nature somewhere, and if there is an animal reservoir, that disease by definition is not eradicable. So no agent has been made extinct. Guinea worm would be the first disease pathogen to be made extinct when guinea worm is eradicated because of its peculiar life cycle. Humans are the definitive host. When humans don't get the disease, the host dies out. I mentioned smallpox, guinea worm. Yaws have been eliminated in India. Plague is very much under effective control, in the sense that control has not been defined, but very infrequent outbreaks only happen. It used to be very common during the last century, early 20th century. Polio, wild polio virus have been eliminated in India, and we are moving towards the end game of eliminating vaccine polio virus, which also can cause polio. Neonatal tetanus is another example. AIDS in India is well on control target. That's because we, how do we know? Because we have denominator-based annual repetitive surveys being conducted for HIV. That's one of our CMC Valor contributions to the national policy. Leprosy, as you read in various journals and publications, is partial success. We, on paper, reached the elimination target, which I don't like the kind of fudging definitions for elimination as less than 1 per, no, those kind of things are not truly epidemiological elimination, but we have pockets in India which there are more than even 4. So I would say partial success. Disease is now under control mode. Tuberculosis since 1962, so this is the golden jubilee year was in 2012. The revised National Tuberculosis Control Program of 1993 is 20 years behind us. These come under the Director General of Health Services, Central Ministry. Malaria, filariasis, Kalasar, as you will hear more during the course of today and tomorrow. HIV/AIDS, I already mentioned. 1986, we established a national task force, and the National AIDS Control Organization strengthened that task force approach in 1992. That also comes under Directorate General of Health Service. Leprosy under DGHS. The Universal Immunization Program has no control, goal, or criteria. It's called routine immunization. It's a ritual. And the target is set in terms of what proportion of children should be vaccinated, which of course is not, in public health term, a clean endpoint. And it comes under the Secretary of Family Welfare in the Ministry of Health, in the central ministry. Polio, of course, is under eradication, and it's the Secretary of Family Welfare who is in charge of polio eradication. So you can see that the disease control what do I call it? I can't call it system. The disease control programs or projects are a little fragmented. So if you look at neglected diseases in India, there is a list put in: anthrax, brucellosis, dysentery amoebic, dysentery shigella, hepatitis A and E, hydatid disease, influenza, leptospirosis, meningococcal diseases. I'm coming from Africa, where we reviewed the African belt success of controlling meningococcal A outbreaks. Melioidosis, we will be having a paper on melioidosis from another country. Rabies, even rabies, rickettsiosis, rotavirus gastroenteritis, although there is some good news about the Indian vaccine. Rubella, congenital tapeworms, varicella, we have a good vaccine, but varicella is not on control goal. Now, this is my personal view. I don't want to hurt anybody's feelings, but the diseases of public health negligence that we have set a goal to control, we have been spending money, but we are not actually controlling that particular disease because of faulty design or faulty implementation, or both. The WHO reports in recent years, 2011, 12 and 13, says India, with 17% of global population, carries 26% of TB burden. Compare it with a country with equal population size, China, 12%. We have more than double, 26%. The annual economic loss due to this one single disease, tuberculosis, has been calculated by the Planning Commission to be $23.7 billion US. And how much do we spend on control? $200 million US during the last 2 or 3 years. And the multi-drug and extensively drug-resistant TB is getting almost out of control. Here the control is the English language control, getting out of our grasp. Malaria, the official annual deaths are reported to be less than 2,000, whereas the million death study and others project it as 200,000. How can that be? Kalasar, not under control, leprosy re-emerging, diphtheria, pertussis, tetanus, measles, JE, hepatitis B, hip disease. Interventions are already instituted, but without control criteria or without denominator-based monitoring. This is the story of TB. I'm showing this slide because it's directly taken from the RNTCP website. You see the blue bars are actually a quarterly total number of cases diagnosed and put on DOTS treatment. Between 360,000 to 400,000 per quarter. That works out to be between 1 and 2 million cases per annum. And this is taken from the Lancet paper a few years ago. The quarterly number ranges from 375 to 400,000. And there is no evidence of decline. I put this slide in because that was up to 2009, now it's gone to 2010. Since then, they have stopped publishing these bar graphs, and there is no evidence that these numbers are showing any decline. Mind you, it would take 20 years before adult TB would decline after TB gets controlled at the infection level. So TB is a very good example if you want to learn epidemiology of infectious diseases and control tactics. I will skip this except to say that in 2011, when we reviewed the data available in the public domain, we found 650 extensively drug-resistant TB isolates reported in Indian literature. At the time, 2011, India had officially recognized one case. The XDR-TB is reported from these limited number of spots, and you can immediately know that's where decent laboratories exist. Where there is no laboratory, you would not diagnose XDR-TB. And XDR-TB is a microbiological diagnosis with drug sensitivity studies. These XDR-TBs, although it was defined only 4 years ago, isolates fitting the definition of XDR-TB had been detected and reported in 1999, 2000 onwards. Malaria, I touched upon that. The proportion of falciparum malaria is growing steadily. Urban malaria is without effective control. Drug resistance is increasing. So malaria is another disease of public health negligence. This shows, again, taken from the Lancet, the proportional increase of falciparum malaria and the fact that Kalasar is still very much with us and is not going away. How a society responds to infectious diseases is a barometer to measure the importance assigned to health. And the response must be both in public health and healthcare levels. An importance given to health, human health, by a culture depends on societal value concepts and knowledge levels. And the value, I mean humanitarian, human rights and ethics, knowledge, economics and epidemiology. India is deficient on all those counts. So, infectious diseases are, in theory, the easiest to prevent, control and even eliminate because they're dealing with one etiological factor. But it has amplification and transmission issues, but it is a single cause disease, whereas non-infectious diseases are multi-cause diseases, far more difficult to control. Every country desirous of development, socio-economic development, had catalogued and counted their IDs and controlled them one by one. Not so in India. The arm of a government in charge of control is called public health. Union Ministry of Health and most Indian states do not have such an arm. So all infectious diseases are left for healthcare response and using healthcare tools aimed to control. Exclusive healthcare response leads to wasteful expenditure of money, hospital beds, times of healthcare workers, and it perpetuates poverty at family level and at national level. So if India is seriously desirous of poverty alleviation, it has to create the infrastructure called public health and control all infectious diseases, which is an impoverishing experience of families. And a nation that does not know how to control IDs will not be able to control non-infectious diseases. The way forward, we must reject the concept of more vertical single disease control programs. There should be better clarity as to who plays what, the central state responsibilities. We need to redesign our health management system. We need to establish public health departments in centers, states, and deploy staff in districts and cities. And we must integrate all endemic diseases into one system of control. We must invest more in human health. We now officially spend 1.4% of GDP. People look at it in different ways. Some people say 1.9, and if you add to that the out-of-pocket expenditure, it may come to even 2%, but ideally 5% or 10% must be spent. The political philosophy or ideology that health of the people is state responsibility, defined by Johann Peter Frank in 1800 in Germany, and has become the principle accepted by all capitalistic countries except the United States and all socialistic countries, or let me say all communist countries and almost all socialistic countries except India. So our Ministry of Health is Department of Health Services, Department of Family Welfare, Department of Traditional Medicine, Department of Health Research. The missing elephant is Department of Public Health. Why does not the government see this? Because the government does not spend much on healthcare. So therefore, prevention will not save funds for the Ministry of Health. It's a fallacy disconnecting family economics from national economics. What do other countries do? As I said, most capitalistic and communist countries accept that principle I just now mentioned. None of our political parties have this ideology. It's unfair, unethical, and unacceptable. This colloquium has an opportunity to resolve that we cannot tolerate status quo. We can declare we have a role in educating government functionaries and the public. We can demand political parties accept the principle that people's health is the responsibility of the state, and recommend a mechanism, whichever that you can put your heads together and come up with. I'm just proposing a National Commission on Public Health. National Commission is a high-power body. It takes 2-3 years and come up with extensively researched conclusions. We had one just before independence, the Boer Commission, it's called Boer Committee, and 10 years later the Mudaliar Committee, which actually functioned as a commission. Thank you very much.
Thank you very much, Dr. John. He has so eloquently brought about the issues, many issues here. He has talked about, actually he has touched our conscience. He has mentioned some ideas to take us forward. For the sake of clarity, we thought that we will have discussions at the end of the second presentation. So we will have next presentation by Dr. Suman. So I request you to reserve your comments, observations, or any queries so that we will have a discussion a bit later. We also have made arrangements here for the presenters to sit here. They can do it. I request my co-chair to introduce Dr. Suman and then go ahead with the next presentation.
Okay. So it's a pleasure and privilege for me to introduce my long-term colleague, collaborator, Dr. Suman Rizal. Suman did his medical education in Calcutta and then did his MRCP and FRCP in UK. And now at present he is holding as a professor of internal medicine at the BP Koirala Institute of Health Sciences, and also in charge of the tropical infectious diseases of the same institute. He's holding many important positions. He's the regional technical advisory group in the VL elimination program of World Health Organization, and he's the member of the WHO expert panel on parasitic diseases, leishmaniasis in Geneva, and is a member Institute Ethical Review Board of BP Koirala Institute, and member secretary HIV/AIDS core group of the Institute, BP Koirala Institute, and member of the clinical epidemiology unit of the same institute, and also the chairperson of strategic network for neglected tropical diseases and zoonosis of the Institute of Tropical Medicine, Antwerp. His research involves primarily on leishmaniasis, and he has done extensive trial on a variety of drugs. And one of the major findings is that the miltefosine, which is the oral anti-leishmanial drug, its efficacy is progressively dwindling, and at present it is about 20% relapse cases. So he's still continuing his research on leishmaniasis. I think without much further ado, I invite Professor Rizal to present his talk. Professor Rizal, please.
To justice in the next 20 minutes or so. I'm not able to deal with all the neglected disease. As you know, it has a very wide list, a long list, but I will try to take a few diseases and try to see what has been the opportunities we have had and where the challenges still lie in trying to control disease, in particular reference to South Asia. This is the list of 17 neglected tropical diseases listed by the WHO, and which has also been carried forward by the different networks and different consortia who are trying to promote the agenda for neglected tropical diseases. Now, they are diverse in their etiology and their manifestations, but one thing in common is they are all related to poverty. It is estimated more than 1 billion people are suffering from these diseases, in more than 150 countries. And in more than 30 countries, they are affected by more than 4 or 5 neglected diseases at the same time. It has an effect not only on these people for the economic sustainability, but also has an effect on the morbidity and mortality, and including delayed treatment in some of the disease causing deaths. And the international community came to a consensus that we do have some tools available at the moment to be able to try to eliminate or try to control some of these diseases. And so this was how the agenda for the control of neglected tropical disease was advocated and taken forward. These are 5 or 6 entities which are amenable for preventive chemotherapy by giving mass drug administration. The concept of treatment of these diseases was initially focused on treating the infections and trying to control the morbidities. But then there was a paradigm shift, and the shift was towards trying to see if we can cater to the needs of the community at large. So this concept of giving a mass drug administration using a safe, effective, and a robust drug, maybe just once or twice a year, would try to prevent these infections. This is a publication which highlights the burden of the entities in South Asia, that's the Indian subcontinent with Maldives. And what we notice here that more than 60% of the world's anthropogenic visual leishmaniasis is in the Southeast, in our South Asia, mainly India, Nepal, Bangladesh. About 50% of the lymphatic filariasis cases are in this region, and about a quarter of the cases of the soil-transmitted helminths are also in this region. So we do have a large burden of some of these diseases which had an effect on the dairies, and it has been estimated that about 5 to 15 million dairies are lost because of these diseases. Now, there are 5 strategies which has been thought would be used to control some of these or eliminate these diseases. As I mentioned to you, the mass drug administration, mainly for lymphatic filariasis, soil-transmitted helminths and trachoma. Along with that, the intensified case management, mainly for Kala-Azar, leprosy, also filariasis and dengue, and then the vector controls. Among these strategies, some of them, like mainly the provision of safe water and sanitation hygiene, are really not much emphasized during our control agenda. The rationale for this mass drug administration was to try to bring down the infection rate in the community at large below a critical threshold, and then trying to prevent transmission at that low threshold, and that would also prevent the re-emergence of the disease to become unlikely. There was also, as I mentioned, other than having the drugs, there was also a campaign that there was many multinational pharmaceutical companies who have been donating and who have promised to donate drugs till they eliminate these diseases. And there was also an opportunity to integrate multiple entities at the same administration, and also to integrate with the community-based interventions using the schools or using the health program at large. Now, what are the possible factors that would make an effective mass drug administration campaign to prevent infections? One of the most important things is the coverage and the compliance, which is critical. For that, it is depending on the health behavior of the community, that is also dependent on the health education and the information they have, and also the mobilization of the community for these large campaigns, which are usually held for a day or 2 or a week. Now, as these drugs are being administered to persons who are healthy, any adverse effect was going to have a very negative effect in the civic society and also in the community. And we have seen, for example, with lymphatic filariasis, there has been adverse effects or side effects right up to 15 to 45% if you do a very close surveillance. And also there has been deaths reported even from India. So this is a very important issue for a success of a program. Is it may or may not be related at that time, but it's very important for the program to look into the adverse effects, the side effects, the serious adverse effects that could possibly occur with these campaigns. Now, for the lymphatic filariasis, the modeling has shown that to have elimination of this transmission, there should be an 80% coverage for 6 years. To reduce the threshold to less than 0.5% microfilaria rate with a baseline prevalence of 10%. Now, along with that, as I said, hygiene and sanitation and vector control needs to also go together for these control of these infections. The efficacy of the drug, which is crucial, and especially if your program gets prolonged. Like we have seen in the lymphatic filariasis program, though it is targeted for 5 years, many places they are continuing to use it for 8 years, 10 years, because they do not reach the threshold. So when you continue to use a single drug or a combined drug for a long time, there is chances of developing resistance to this drug. There has been no reported resistance in India, but there has been some reports of resistant genotypes shown from Africa for the lymphatic filariasis campaign. Another important tool which is required during the elimination strategy is to have an accurate tool which can be easily applied to the field. And for example, in filariasis campaign, at every stage of the campaign, for example, in the identifying of the sites, when you are doing the mapping, or when you are evaluating the impact of your drug, or when you want to decide when you want to reach the end point, and after post-drug surveillance, after a few years after you have stopped. So at that every point, diagnostic tools are very important to give you that information. And initially, it was, as you know, most of this information was doing this very difficult collection of blood to detect the microfilaria at the middle of the night. But now you have the circulating filarial antigens in the immunochromatic forms, which have been shown to not only for the mapping, also to look at the impact and also to decide when you reach the end stage. Now, this is if you do not do anything in a community, the infection may remain endemic at the same level, the prevalence at the same level. When you apply the mass drug administration campaigns, the infection rates in the community tend to continue to go down, and then you reach a certain stage and you stop. But if you stop early, then you fail, because then you have a resurgence or recrudescence, and then it goes back to the same level. But if you continue to do for a longer period of time, then you have a risk of using unnecessary resources. So it's a very complicated decision as to when you would like to stop, because it involves a large amount of resources and manpower, energy. Now, this is a publication from a few years ago from India, and to look at the review, and they have been able to cover all the areas identified for the lymphatic filariasis campaign. And if you see the magnitude of the endeavor is distribution more than 1 billion tablets of DEC and 500 million of albendazole by more than 1 million drug distributors. But the coverage has varied depending on the developed and the different states. The well-developed states, they had a good coverage, even reaching up to 90%. But the less developed states was only 1/3 of the population was covered. And modeling, as I showed you earlier, they expected at least around 75 to 80% coverage would be required if you want to end the campaign in 6 years. Moving on to the visceral leishmaniasis, as you know, in the Indian subcontinent, there's only human-to-human transmission, and it is a fatal disease if you delay treatment. And even, but there was a campaign for the elimination was launched in 2005. And I think one of the triggers for this elimination campaign was the political commitment. As you know, we had a Kalazar expert who was the health minister and who was committed to take on this endeavor. And also along with that, there was certain tools which became available. For example, we had an oral drug which could be given for the first time, and you had a very easy rapid diagnostic test which was found to be quite accurate. Now, the two main strategies in the control of Kala-azar are to reduce the reservoir, that's mainly the patients, that's early diagnosis and treatment, and then secondly is to control the vector by integrated vector control strategies. Now, in the early diagnosis and treatment, active case finding is crucial. What we have seen is, even with provision of free diagnostic and drugs at the primary healthcare level in Nepal, people still tend to take a long time to reach this health facility because their health-seeking behavior guides them to other pathways. And then they not only come late, but they also have spent a lot of their money and resources before they finally reach the health center that provides them the treatment. It's also crucial to have an accurate point of care diagnostic tool, because the drugs we use are quite toxic and can also be cause deaths, and also to ensure the compliance of therapy to prevent resistance of the drug therapy. For the integrated control strategies, we have the IRS spraying of the households, maintaining hygiene and environment, and providing of insecticide-treated nets, which is being done. Now, these are currently the only drugs which we know are used to treat Kala-azar. And out of them, the antimonials are no longer used because they have developed resistance. Ambisome, which was out of reach till a few years ago, has been made available due to the decreased price and donation by the pharmaceutical company. And miltefosine and paromycin, these are drugs which have been developed in the last 1.5 decades. And I must emphasize that there was a good public-private partnership which has expedited the delivery of this or made this drug available at quite an early, in a few years. Now, it has been reported that antimonials is less than 40% effective in Bihar, but we still see reports of it being used in the country. And miltefosine, recently we've also shown in Nepal that although it's a very effective drug and initially, but it has now shown that the long-term cure rates are quite high proportion of patients to relapse even with initial cure. They are contraindicated, some of them are contraindicated in pregnancy, they require prolonged therapy, and there's a reduced compliance. So there was an effort to try to see how we could overcome these shortcomings. And there was 2 studies which in the last 5 years, which has been quite impressive, was a use of a single dose of a liposomal amphotericin B had a cure rate of more than 95%. And similarly, efforts to try to combine these available drugs have shown that there were 3 combinations which was tested, and all of them were shown to have effective cure rates with very low side effects. Now, that would mean that we could straight away jump into and start using these drugs, but unfortunately, it's not so simple because it was very difficult for the programs to adopt these new regimes in the system. So now currently there have been large-scale public health studies are being conducted in India and Bangladesh to see the feasibility and how easily we can adapt these new regimes into the control program. So there is a long lag period from the proving an effective drug and even having it freely available to trying to implement it in the health services. Regarding the vector control, the IRS is found to be very effective, but it's an inherent, the problems include not only the cost, but also you have to monitor the quality at every level, right from the procurement, transport, and also when you are spraying. So it requires a lot of monitoring, and which is, as you would realize, it's very difficult in the field situations. Similarly, there has been reports of insecticide resistance, which have been documented even from some places in Bihar. Now, the next option and a better option would be to see if long-lasting nets would, as it is driven by the community and the person themselves, if that was found to be effective in vector control. But unfortunately, the last study, a community study we had conducted in collaboration with India and also the Tropical Institute in Antwerp, showed that in itself it was not sufficient to decrease the infection of Leishmania. Now, Bangladesh, we have been observing their control programs for the last 10 years or so, and what we noticed was they did not have a vector control strategy till 2010. And after they have started using the vector control strategy, you can see there's been a dramatic drop in the caseloads in Bangladesh. So treatment itself per se is probably inadequate, and you need to have both these prongs working effectively at the same time. What are the challenges? We still have some things left which would probably not help us or would prevent us to reach the elimination targets. One is an entity called post-Kala-Azar dermal leishmaniasis. This occurs in 5 to 15% of those Kala-Azar patients after they are cured, and they are also reservoirs, but then it is very difficult to treat. And then you have the asymptomatic carriers. There are 9 times more infections than cases, and we really do not know whether they play a role in the transmission, and we do not have very good tools to diagnose both these entities at the present moment. Now, HIV-VL co-infection, we mustn't forget, although at the present state in the Indian subcontinent, this is not a major problem. And the other factors are we need to improve the delivery system in the health services. We need to have also better coordination for cross-border issues because the endemic regions are quite contiguous. Now, some other important measures in control of neglected tropical diseases, especially if you want to have a long-term and sustainable impact, is the provision of clean water supply, hygiene and sanitation, the behavioral changes which would take a long time and long effect. For example, yesterday it was we had a poster session where we looked at whether toilets are being, in the different community, in the villages in Africa, in Zambia. And one of the reasons, if they are using the toilets, and even in spite of having a toilet in the house, they were not using it because there were some cultural differences between the genders. They would not be using the same toilets of the same 2 different genders in the community. So these aspects are never taken into consideration when you are designing control programs. And vector management for many of these diseases. Obviously, the impact of such programs have an effect on the control program or the health systems. So there needs to be a very good integration so that you do not overburden the program with these different types of implementation strategies. And you definitely need to strengthen the capacity of the primary health system, which has been very nicely and demonstrated by Professor Jacob John in his early presentation. Now, one of the things as being also a clinician is where we look at patients when they come to the health facility. And suppose you take an example of VL, a Kala-Azar, which presents with fever, and we have a patient who comes to the community with fever. We do have a program where we have a diagnostic test to diagnose Kala-Azar, but then the ones which are negative for Kala-Azar, we do not really know what to do at that primary healthcare level because we do not have any other tools easily available that can be applied there. So what eventually happens is either the patient gets referred or the patient is given a cocktail of different drugs to cover the different common infections. So this is also something which needs to be looked into, and currently there is a project which we have launched. It's almost halfway through. It's been coordinated by the Institute of Tropical Medicine. We trying to look at if we can improve the diagnosis of these different syndromes, the fever syndrome, the digestive syndrome and neurological syndrome, using the currently available RDTs, and try to see if we can develop algorithms as seen with other types of disease syndromes. Now, will we be able to reach the 2020 targets for most of these disease for control and elimination? And this was a slide I picked up from one of these NTD campaigns. And the thing with with the current tools, we will probably never reach those targets, and there is a need for better tools for both diagnosis and treatment. Now, this is we have always been hearing about the 10-90 gap, 10% of the resources being allotted for 90% of the disease which affected 90% of the population. But here, this was looking at what has been the innovations regarding the drug developments, and what they have found out from 2000 to 2011, out of 850 total products approved, only 4.4% was for neglected tropical disease, which constitutes about 11% of the total diseases. And if you look at the new chemical entities, there's only 1.2%. That's only 4 out of the 336 new entities that were developed. But then, if you look at also the funding which has been allocated for research, for example, in leishmaniasis in the US, more than 2/3 of the fund were used for basics research or biomedical innovations, but very little, less than 10% for epidemiological and implementation research, which is one of the main challenges in the control programs, is how do you implement your tool, is we need more investment in operational and in epidemiological research. Now, looking at the coverage of piped water and sewerage, and this is, if you look at from the region-wise, the South Asia is the light blue colored. And the shaded area is in the current last 10 years, 20 years. We see that it's about, coverage percentage is less than 10% of the population have access to piped water and sewerage. And if you look at the current or the historical growth rates which we see, by 2050 we would be maybe reaching about 35%. But then if you look at the populations with piped water, sewerage who do not get, it seems that this will be increasing because of the population growth. So with the current growth rate of supplying piped water and sewerage, in 2050 there will be more people without piped water and sewerage as of now. So this is a very striking graph which I came across. Now look at the costs which have been involved. Almost $1.75 billion are being projected to cost for just the procurement of these mass drug administration tablets. So cost is a major factor for these large campaigns, and obviously so it cannot be sustained forever. Conflict and migration. We don't have such problems at the moment in our South Asia region. It's more a problem in Africa, but that could have a limitation for the access. And climate change, as you know, which we really project from 50 years from hence or even longer. But then we are seeing, for example, in Nepal, that nowadays we are seeing many Kalaza cases coming from the hilly districts. That could be due to migration, or that could be due to local transmission added on to migration of infected people from that region. Now, there has been one of the positive developments is partners. We've not only healthcare providers, but also you have philanthropic organizations, pharmaceutical companies, academia. They are all joining hands to try to build up a consortia to try to get more advocacy and also get funds. But these partnerships have to be very sustainable and for a long term. And there also needs to be some very good harmonization, because we do not want them to repeat the same things and avoid overlapping of the activities. So lastly, this is my last slide. There's nothing addition to add, but just want to conclude that this campaign for the entity, the roadmap which has been earmarked, which we are following, the most programs are following, is very ambitious and costly, but it needs to include other strategies, for example, the provision of safe water and also vector control activities. And also, I think both development of new tools and strengthening of the health systems have to go together. And there is no choice that you want to only stick on to one strategy. But thank you very much.
Thank you, Professor. They have highlighted the epidemiological principles in either the control or the elimination or the eradication of these neglected tropical diseases. They explained to us the burden, some of the issues, the challenges which we are facing. They have also mentioned the possible solutions that are possible. So I propose a round of discussion now, and you are welcome to have any queries, observations, or clarifications. Let me set the ball rolling by making one or two observations on these two presentations. Dr. Jacob John, as I mentioned earlier, has really touched our conscience. He has mentioned that there is almost as if there is no intention to control many of these neglected diseases. He's also mentioned about the public health negligence that is rampant in our setup. But at the same time, let us also remember some of the improvements or some of the opportunities which have been given to us by these neglected tropical diseases. A couple of years back, we had an outbreak, or rather the emergence of influenza. In one of his presentations, Dr. Jacob John mentioned about some certain list of diseases. When H1N1 broke out in the country, it really brought to the fore the need for the capability or the need for strengthening. It really tested our system. The Integrated Disease Surveillance Project was at its peak, and the response of the public health system was shown to be excellent during this outbreak. We started with the implementation of these international health regulations by screening of the incoming people for any suspected case of H1N1. So we were ready. We were at the airports or seaports or road or whatever. There was an element of screening that was possible. The second aspect was the outbreak investigation. It showed the capability of our response mechanism in which a person from the district level will go to the farthest corner of the district in conducting a possible outbreak investigation. More than anything, it showed us the capability in testing of a sample. During the time of H1N1, it made us possible for bringing a throat swab from a remote corner to the testing laboratory at the state capital within a matter of hours or within one day. It showed us that we need to have more of these molecular diagnostic facilities available at different states, at least one in every state, and if possible more in every state. So we have shown that we can use these opportunities whenever it arises. During the second presentation, Professor Suman mentioned about the lymphatic filariasis. We will have a detailed presentation on lymphatic filariasis by Dr. Pradeep Shrivastava, who has just walked in. In one of his slides, he made an observation that the challenges that are being placed by the mass drug administration. He also mentioned about some published papers showing the adverse effects of these DEC or co-administration of DEC with albendazole, where some of the research publications have shown us that the adverse effects can be as high as 15 to 45%, which can be a challenge. But let me mention here the observations which we have seen in the last few years. There are 250 districts where we take up MDA in the country, and in each of those districts we have a system of independent evaluation by external faculty who will go and conduct this evaluation in these different districts. They also ask a question, apart from measuring the compliance, about the adverse effects which people have noted. And most of the data that has been generated from these independent evaluations, many of them are published, many of them are not published, has shown us that adverse effects are to the tune of just 1 to 3%. So the adverse effects have not been a major challenge to us in the program so far. He's also mentioned about the Kala Azar. Wonderful presentation. Now I request all of you to have any queries or observations or whatever. I also request my co-chair if he has any pressing remarks at this stage to make. Otherwise we will have the floor open for discussion now. I request you to identify yourself and then ask a particular question to any of the people on the dais.
The experience with H1N1 pandemic influenza is very educational in India. That if a problem is identified, the news of H1N1 came to India before H1N1 itself came to India. So the Central Health Ministry was well prepared. They had all the interventions listed, to screen people as they come in, to try to prevent the virus coming in, and even H1N1 vaccines were made in India, live intranasal vaccines. It was done on a very professional basis. And H1N1 is now part of the seasonal influenza. So how well do we do seasonal influenza work? We are back to square one. That is where a system has to be established. So ad hoc management of a particular SARS was another example. The screening of SARS and identifying suspected people and then tracing them and family contacts and investigations, molecular virology, etc. was excellently well done. These are ad hoc, immediate response against a particular single agent disease. Tools are available, tools are put together, people are trained. But once that is over, then the system falls back to its unsatisfactory routine level. So we don't have a policy on influenza vaccination in India. We have very little epidemiological studies of influenza. So we have not learned lessons from H1N1. We do have a network of laboratories identifying influenza strains, and that is fed into the WHO system in recognizing what should be the next vaccine formulation for the Northern Hemisphere. And we do not use that data for addressing influenza problem within the country. And most people even do not know what the results are. So there is no bulletin that the public health system or the government publishes on a monthly basis saying that this is the seasonal influenza in India and the best fit vaccine for you is the Southern Hemisphere vaccine or the Northern Hemisphere vaccine. Nobody makes those kind of recommendations. So people are on their own. So the example you showed is an excellent example of how we can shape up if we put a goal in front of us. And the goal I am presenting, or I am proposing, is that we look at the whole health management system and try to learn lessons and try to improve.
Good morning. My name is Kea Furtado. I'm from the University of Pune, PhD fellow there. Dr. Jacob John, I was just wondering, we've heard you speak on several occasions on the importance of the creation of a department really to address public health. You know, you've said this many times, something that we've seen in Tamil Nadu as an example that can address the multiple challenges faced by public health in the country. But until that happens, I was wondering, one of the issues in this country is disease surveillance. It's one of the basic problems that we have, the lack of surveillance. And recently we did introduce the Integrated Disease Surveillance Project. Now, for those of us who work in the field, we've seen that IDSP has not really taken roots the way it was planned for, and especially in urban areas. So I was wondering if we can at least start, if there are people here who have connections to this program, because I see the IDSP as a potential tool to address at least the major aspect of disease surveillance and the lack of data required for the control of infectious diseases. So what mechanisms can we put into place to really strengthen the implementation of IDSP in a sense, since it can be the link between the collection of data and those vertical programs that actually seek to address the control of certain diseases, like, say, the National Vector-Borne Disease Control Program or the immunization program, which are just, delivering services but not really, do not have a connect with how they are impacting the overall health problem. So can you, elaborate on how IDSP can become a better program, and also how it can create infrastructure within urban areas which does not have that defined, three-tier system that rural areas has, and how that can be maybe one of our first steps to address the problems of infectious disease control in India through the public health system?
You put your finger on the spot. That if you want to control a disease, you have to establish surveillance first. And it is not possible to have single disease surveillance for rotavirus, a particular surveillance, for malaria, a different surveillance. That's not possible. You have to have an integrated surveillance system, absolutely correct. And the intention of the integrated disease surveillance system, IDSP, is exactly that, and it is highly laudable. Why is the implementation not satisfactory? I have two reasons that I would suggest. One is that public health surveillance is information for action. Information for action should be like the spinal cord neuron, an efferent message and an afferent message and an efferent response. So unless the response occurs at the local level, say at the district, there are 5 cases of some fever, maybe enteric fever, and the district system comes in, investigates, is it enteric fever? No, it is not. It is leptospirosis, then do control. So that immediacy of response is lacking in IDSP. IDSP functions as a statistics collection method of disease surveillance. So we need to closely examine IDSP and improve on it so that we can achieve success through IDSP. The second reason is the center-state relationship in health management. The IDSP is a central project, it's almost like a vertical project, implemented by state players but funded by the center. Do you know that the entire health ministry, the entire Directorate General of Health Services in India consists of 3,900 personnel? You will probably need 400,000 people if you want public health to be active in India. So unless a department is established, cadre structure is made, and it comes down to right down the sub-district level where public health functions, I don't think IDSP will be successful in controlling the multifarious neglected infectious disease. We do have IDSP, and we need to redesign it, and we need to redesign the health management system to fit the two together for functional efficiency. That's my little long-winded, but
make a quick comment on that. The Karnataka experience of IDSP has been really fantastic. We are ranked 1 in the country as far as the running of this integrated disease surveillance project is considered. What IDSP has done is to have a decentralized decision making. You were talking about analysis of data. Dr. Jacob John also mentioned about the analysis of data. Now, because of the availability of the online mechanism and the fact that 95% and above health institutions report on a weekly basis, speedy data entry. Now, the information is made available at the district level itself. So we have measured the response time, and over the years we have brought down the response time to within a matter of hours. From the time the source of information is validated, within a matter of hours, the district rapid response team would go to the field and investigate. We have also improved tremendously in our diagnostic capability. the number of outbreaks, if you see, and the number of outbreaks in which the causative agent has been established, that is also has shown a tremendous improvement. So what IDSP has done is to strengthen the systems. Bit of fine-tuning is required. Now a lot of money is also made available now to IDSP. Under the NRHM itself, as I mentioned yesterday, we have moved away from a project mode, from a World Bank funded project mode to the routine, the National Rural Health Mission mode, in which sufficient funds are made available. So availability of computers, availability of internet facility, availability of an online software, taking of outputs from this software, using that information at the district level has all shown tremendous improvement. There is a need for a bit of fine-tuning in that. Any other question?
Thank you. My name is Dr. Subhash Salunki. Dr. John, you have given a very broad kind of a picture, and which I feel has a lot of substance, which clearly points out what are the areas where any developing country, including India, needs to be looked at it from the comprehensive point of view. But don't you think that the health system, and not only the control of neglected diseases, it's overall, if a robust health system exists, it will tackle not only the neglected diseases, or it will tackle other diseases also, or the all required public health functions. So basically, what fault lies, or whatever the gaps are, is about looking at the health system and developing it in that particular fashion. And you still go back, then you will realize that you take an example of India, wherein you will find, say, Karnataka. Comparatively, Karnataka, Tamil Nadu, or southern states are doing comparatively better. This is also related to overall governance. The governance of not only, you cannot expect in a given country that only one ministry or health will do excellent while others will do mediocre, or their performance is mediocre. That doesn't happen. The political setup, the administrative setup, and the decision making and overall governance is reflected everywhere. These are the basic issues which unfortunately we'll have to take into account. That's the reason what's happening in some of the northern states, and why Tamil Nadu and Karnataka, including my own state, Maharashtra, we used to feel proud about it, because of the fact overall governance resulting into appropriate strengthening of the health system, reflecting into various aspects of public health. So this is the basics. What has happened, we have been trained, entire health systems in the India has been designed at the central level, state level in a silo. We think in silo. If I am a chief of a program, I don't bother about others. That kind of an verticalization or silo is one of the major impediments in this entire affair. That's what I personally feel. What are the solutions for that is not going to be easy. But the fact remains, wherever there are proper leaderships, proper governances, and focusing on the health systems, things do improve. And I fully endorse what you have stated about the neglected diseases. It is neglected diseases are, after all, these are diseases of poverty. And who wants to take care of the poor? It's only speeches that are supposed to be poor, and speeches, that's the equation. That's what, at least in this country, is happening. Thank you.
I cannot agree with you more. I totally agree. When Osler said that health is politics writ large, he did not know India. Because in India, at least at the political level, health is not given the due importance that it should be. It's a political issue. Lack of equity or lack of conscientiousness of the top level politicians looking after their health at any cost and neglecting the health of the poor people is unacceptable. So I think we need to bring health up on the political agenda. At least the present government, the present party in power in Delhi, in its manifesto, election manifesto, had a very interesting statement to make. We will provide health equity for all. I have read through all the political manifestos of all the parties, and only 3 parties have mentioned health in it, And the Communist Party said they will increase the health spending, but they do not know how. And okay, some other parties have no mention on the health. So I have challenged people in Delhi as to please define health security. Please define what you mean by health security. And people duck that question. And if we can define health security and challenge the present ruling party, even next election we don't know who will come to power, I think we need to raise the level of health in the political agenda. And that's our role as a group, as an institute, as network of people. We need to struggle to get health up on the political agenda. And what is on the political agenda is reflected in the economic spending of the budget. So those two go hand in hand. Health ministry will not be able to influence within itself, from inside the political thinking. We need activism, we need advocacy, we need more publications, we need political thinkers addressed, we need to confront politicians, and we need to ask people when they stand for election, what are you going to do for health? I was very pleased to know that in the Delhi election discussions, health has come up, polio eradication has come up, which is a good sign.
Quick comments on the issue raised. Two issues were raised. One, the role of IDSP, how it can be integrated with the disease surveillance program. Reference were made for malaria and other neglected diseases. The other bigger question was raised that how it can be integrated for urban dwellings, urban areas, which is really a challenge. To answer the second question, I'll just wait. I'm Pradeep Srivastava from Vector-Borne Disease Control Program. And since I'm heading the policy division also of vector-borne disease, let me clarify that wait for a few months. Urban Health Mission has already come up and it has been overarched under National Health Mission, which encompasses both National Rural Health Mission and National Urban Health Mission. And there are plenty of things which are coming up. We are just waiting, as very rightly told, that we are waiting for the new governance and the scenario of post-election. But there are many issues which are coming up under Urban Health Mission, and the states are being sensitized. How this surveillance program for communicable as well as for non-communicable diseases, CD and NCD both have to be incorporated in that, and there are plenty of agendas coming up. Just wait for a couple of months. Disease surveillance program, as very rightly Dr. Salunke was telling, that we have been working since 1950-55 onwards in different domain. This is my domain, and that is your domain, and this is your domain. IDSP was started with a different approach to give a warning signal initially on a very small project. Now in some states it has really been integrated. Some states it is yet to be integrated, but even the states where indirectly reflections are being made in northern states, I'll give one state example where IDSP has been able to forewarn the program implementers, which is whether it is a vector-borne disease, for Kala-Azar, for Japanese encephalitis control. This was, IDSP has played their role, that they have been able to warn, look here, this is the place where you are going and getting more number of cases. So the program implementers at the district level and at the state level, even from central level, from our team, they have been able to get the points and rush to the spot and tackle the problem. This is what I just wanted to add. Thank you.
Meghalaya had a meningococcal meningitis epidemic starting in 2008. It was picked up by the surveillance system in 2010. And immediately investigations took place. It was meningococcus A, and they identified the age group, and vaccination program started. But took about 2.5 years for that action to take place. So yes, in theory, we have everything, but in practice, we have not learned to put them together faster.
If there are no further questions or any observations, we'll move on. I thank Dr. Jacob John and Dr. Suman for raising very important issues. We'll proceed with the presentations, oral presentations. The first presentations will be by Dr. Gudadappa Kasabi. Now, he'll make the presentation on investigation of Kasner forest disease. Dr. Gudadappa is working as Taluk Health Officer in one of our districts in Karnataka, in Shivamoga. Now, as a Taluk Health Officer, he has participated in the recent outbreak investigation of Kasner forest disease. He has already published a couple of papers on KFD, and he is also a public health specialist. I request Dr. Kasabi to go ahead. You have about 12 minutes.
Okay, sir, thank you. Good morning, everybody. Today I am presenting an outbreak of Kasner forest disease in Bandipur National Park of Chamarajanagar district in Karnataka, which occurred during 2012. This study was conducted by Department of Health and Family Welfare, Government of Karnataka and Virus Diagnostic Laboratory, Shivamoga, under the supervision of National Institute of Epidemiology, Chennai. Kasner forest disease is a tick-borne viral disease. This KFD virus belongs to a group of Russian spring-summer encephalitis virus. It was first recognized in 1957 in Kasner forest in Shivamoga district of Karnataka, when there was unusual death of monkeys followed by acute febrile illness among humans. And it presents with sudden onset of fever, myalgia, headache, GI disturbances in the early stages, and later stages it may present with hemorrhages and meningoencephalitis. This disease is unique in 5 districts of Karnataka, which are highlighted with green color. This is the Malnad region of Karnataka. These include Shivamoga, Chikmagalur, Uttar Kannada, Dakshina Kannada, and Udupi. KFD occurs as seasonal outbreaks during January to June. During this time, when we see the life cycle of the tick, nymphal activity in the forest is maximum. These nymphs are anthropophilic and very active, so all the outbreaks occurred since 1957 to date are coincide with the nymphal activity. This, I picked up this slide from the Virus Diagnostic Laboratory. It shows incidence of Kasner forest disease since 1957 to 2013. This blue line indicates suspected cases, and red line indicates confirmed cases, and light blue line number of deaths. Since 1957, over the period of 56 years, 27,000 cases were reported. Out of that, 7,000 cases were confirmed and 800 deaths were reported. There is a vaccine for Kasner forest disease. It is formalin inactivated tissue culture vaccine. We have to give 2 doses of 2 doses of vaccine at the interval of 1 month for the individuals aged 7 to 65 years. As the immunity conferred by the vaccine is short, we have to give booster dose at 6 to 9 months, and then after periodic boosters. Coming to outbreak of KFD in Bandipur. In the month of November 2012, we received information from the veterinary doctor who is in charge of Bandipur National Park about the unusual death of monkeys, and there are acute febrile illness among the forest watchers working in the forest. So we rushed to Bandipur and we investigated the outbreak to confirm the etiology, to estimate the magnitude and treat the patient and propose the recommendations for control in future. We defined suspected case of KFD as sudden onset of fever, headache, myalgia among the staff of Bandipur National Park since November 2012. Our trained health worker searched for the cases actively, and we collected blood specimens from all suspected cases. We did monkey autopsy and collected viscera samples for the laboratory, and we also collected tick pool specimens from the forest. And all these specimens were tested at, using RT-PCR at National Institute of Virology, Pune, which is a reference laboratory for viral diseases in India. We analyzed the data to describe the disease by time, place, and person. 6 suspected cases were identified among 400 forest workers and forest watchers. Attack rate was 15 for 1,000 persons. All cases were male aged 22 to 25 years. And out of 6 cases, 4 cases were laboratory confirmed by RT-PCR. The symptoms, fever, myalgia, headache, conjunctival congestion were reported in all case patients. In addition to these symptoms, 2 had vomiting, pain abdomen, and facial swelling. As additional investigations, there were 9 monkey deaths were reported from Bandipur. We collected 7 monkey viscera samples from 3 monkeys, and out of 7 monkey viscera, 3 samples were positive. And one out of 2 tick pool samples were found positive for KFD virus by RT-PCR. All the case patients were handled carcasses of dead monkeys prior to their illness. This graph shows the distribution of Kastner forest disease cases by date of onset, 2012. The x-axis indicates the date of onset in the month of November, and y-axis shows the cases. The cases started occurring in the 19th of November and peaked after 2 to 3 days and declined then gradually. The line indicates number of monkey deaths. Prior to the onset of outbreak in humans, there was monkey deaths. Total 5 monkey deaths before the outbreak in humans. 3 monkey deaths on 19th of November. To conclude, our findings confirmed the outbreak of Kastner forest disease in Bandipur. This was the first report of KFD outside the 5 endemic districts of Karnataka. Which is highlighted in orange color is the Chamarajanagar district, where the Bandipur National Park comes. And the cluster was associated with handling of dead monkeys. And we vaccinated all the forest watchers with KFD vaccine. We vaccinated 322 forest workers and forest watchers with formalin inactivated tissue culture KFD vaccine. And we admitted all the patients to the nearest hospital, General Hospital Gundulpet, and we sensitized the medical officers and treating doctors about the Kastner forest disease, and all the patients were recovered. And we advised all the forest workers to use tick repellents before going to the forest. I thank Institute of Public Health Bangalore and Institute of ITM Antwerp for giving me this opportunity. And also I would like to thank Department of Health and Family Welfare, Chamarajanagar District, and Conservator of Forest and the staff Bandipur for their cooperation during outbreak investigation. And also I thank National Institute of Virology, Pune for their laboratory support. Thank you very much.
Thank you so much, Dr. Kudadappa. It has been a nice presentation of a outbreak investigation. I would like to quickly add a few comments to this because this is a kind of a historic event in Karnataka. The textbooks have been written on Kastner forest disease, have talked of a limited focus of Kastner forest disease in 3 or 4 districts of Karnataka. Now for the first time we are seeing Kastner forest disease extending to other neighboring districts also. In fact, extending to neighboring states also. However, what it has shown is the response again of the mechanism, and then the role of the collaboration between the health and the forest department here, and the collaboration between different states. So we recently had a border meeting between the Kerala, Tamil Nadu and Karnataka on Kastner forest disease. This outbreak also showed us that we have to invest more money in the vaccines. Now Karnataka has indigenously produced the vaccine for Kastner forest disease. We have been giving it to a limited number of people, so probably this outbreak has shown us that we have to have more resources to have more vaccine, and we have to vaccinate more people, and we have to be better prepared. Thank you so much. I think we will take the questions at the end of the three presentations. Now I call upon Dr. Surendra.
Thank you, sir.
Surendra Uran now would make the next presentation. We have Dr. Surendra here? Yeah. Dr. Surendra is a PhD from the ITM and ULB Belgium. He has also done his PhD from Kerala also on the causes of epidemiology and control. He is currently working at the Tropical and Infectious Disease Center of BP Koirala Institute at Dharan in Nepal. He is an avid researcher, and he has got a long working experience in causes control. Dr. Surendra, please.
Thank you very much. Good morning, everybody. Today I'm here to present our research findings, especially in the qualitative study on the healthcare provider diagnosis and the referral practices related to the neglected tropical disease, especially in persistent febrile syndrome in eastern Nepal. As you all know, the febrile illness is one of the most common reasons that lead to the people to seek medical attention at the health facility in anywhere. And the available diagnostics and the treatment options for these common neglected tropical disease and infectious disease are limited, especially at the primary healthcare level. And both healthcare provider and the patients face significant challenges regarding the diagnosis and the management of such infectious disease in peripheral health settings. This is the part of a big project, as already mentioned by Professor Suman, that the NIDIAC, which is working on the development of diagnostic algorithm for neglected disease. This is a small component which aim to collect the information that will lead to the better understand the current clinical management and the referral practices in relation to persistent fever syndrome of primary health care providers and health facilities, and will facilitate these findings to design training and educate the healthcare providers that needed before the implementation of the diagnostic algorithm into practice at primary healthcare level. So for this study, we have a set of 4 research questions. Number 1, what is the general level of knowledge of the healthcare providers in terms of persistent fever syndrome at the health facilities? Second one, what is the current diagnostics and referral practices existing in relation to persistent fever syndrome? And third one, what are the different providers' guidelines? Relevant existing guidelines, they are available at the health facility. If available, do they use them? If not, why not they use the existing health protocols for persistent fever syndrome at the health facility? And the last one, what are the different barriers they perceive to diagnose and refer the patient to the higher centers? So coming to the methods, this is an exploratory qualitative study designed to better understand the existing diagnostic and referral practices. For this study, we have 3 different approaches sequentially organized the observations of consultation process of the healthcare providers at the health facilities, followed by in-depth interview and the focus group discussions to explore the problems and the barriers related to the diagnosis and the referral practices. For the data collections, we collected almost 40 non-participant observations by using pre-test consultation checklist, followed by in-depth interview using pre-tested clinical vignette, especially based on the sign and symptom of dysreligious using question guides. And third one, we did a focus group discussion at the different health facility. And we conducted this study at the 4 healthcare facilities, namely 1 in each primary healthcare centers, 2nd at the district level 1, and the zonal level 1, and the last one is the tertiary care hospitals. And all the healthcare providers who were working at this facility and perform the daily basis consultations were the study population for this study. Coming to the data analysis, we note all the relevant observations of the consultation process of the healthcare providers, and we interviews and the focus group discussion were recorded and transcribed, and data analyzed by using the in vivo and qualitative analysis softwares. Coming to the results, in results we have categorized in the different parts. Number 1, the familiarity with the syndrome, that is persistent fever syndrome. Actually, we observed that the familiarity with the persistent syndrome was limited among the healthcare providers, although they know about the associated symptoms and the infectious disease was good. And we also asked what the describe what they understand about the term persistent fever syndrome among the healthcare providers. They replied that they define as persistent fever syndrome was equal or more than 2 weeks of fever associated with the symptoms like general weakness, headache, myalgia, loss of appetite, etc. And I have also quoted one voices from the hospital clinicians that he said, I have never heard the term persistent fever syndrome in my clinical practices or even during the studies. These are stated mentioned by the healthcare providers in the terms reference of the persistent fever syndrome. About the existing diagnostic practices, we observed 2 different types of diagnostic approaches they commonly used at the healthcare facilities. Symptomatic treatment and the diagnosis was made at the primary healthcare level, which is mostly practiced by healthcare providers at the primary healthcare level. And second one, the diagnostic-led diagnosis and treatment at the zonal and the reference health center. This is mostly practiced by the clinicians at the reference level of hospitals. Coming to the barrier to diagnosis, we have found a lot of barriers to the diagnosis at the primary healthcare level, mainly understaffed, undertrained laboratory staffs, lack of reagents to the diagnostic at the peripheral health level. And we found some of the quotes which is very interesting related to the barrier to the diagnosis was like the most important are the clinical elements, and they diagnose the cases, the persistent fever syndrome based on the clinical sign of symptoms, and they are the main fundamental clinical elements that guide us to treat the patient at the primary healthcare level. And from there, we have additional laboratory tests done according to the possibilities of their patient choices. So these are the common practices laid at the primary healthcare level. Similarly, they are not sure to diagnose the patients, and this is really the practice at the primary healthcare level. Like here, they mention one PSC health assistant, and the nurse mentions that we are not sure really. We don't pose diagnostic certainty because we lack of diagnostic material to do so at the level our setup. So these are the system, these are the practice, they have faced the barriers to diagnose the persistent fever syndrome cases at the primary healthcare level, and these ultimately led to the treatment without etiological confirmations, and these lead to the misdiagnosis, underdiagnosis of the cases at the primary healthcare level. There are some patient expectations we observed and we found during the in-depth interview, like for the patient, laboratory tests, they don't consider it to be their business. According to the patients, they expect doctor, they are God, they to treat them based on solely their experiences and complaints. It is a culture they face day-to-day diagnostic practice at the primary healthcare level, this shared by the hospital clinician in one of the focus group discussion. Similarly, the use of protocol, and we didn't found any specific protocol they mentioned about the management and the diagnostic practices of the persistent fever syndrome at the health facility, even in the reference hospital. And some of the specific protocols we found at the health facility are mainly disease-specific, like tuberculosis, malaria, diarrhea, management of diarrheal disease, and some of the filariasis disease, and community-based management of integrated illness. These are available commonly at the health facility level, but we didn't found the specific protocols and guidelines mainly designed for the persistent fever syndrome at the health facility. Similarly, the practical consideration regarding the availability of the protocol, I don't consult such documents in front of patient because I don't have time for it. This is a practical consideration. Whatever they have available, the availability of the protocols for their management of the disease at the health facility, they didn't want to use due to the practical consideration. Second quote they have mentioned in the focus group discussion by the one hospital clinician, reading available protocols in a busy outpatient department or during the clinical consultation is impractical totally, and patient might think that doctor is not knowledgeable or new or maybe unexperienced, said by one hospital clinician. Similarly, the available guidelines are too specific or too complicated, not user-friendly. Similarly, one nurses acknowledged during the focus group discussion. So, though the available diagnostic tools like other specific neglected diseases are available, but due to the practical consideration they are not using on the regular basis for the consultation of the patient at the health facility. We found several barriers related to the referral practices. Among them, the 4 are the major barriers to diagnose the patients where they confronted with the other neglected disease, including the persistent fever syndrome at the health facility. Out of them, financial concerns, delays in seeking health care at the health facility, likewise community beliefs and folklore, and the geographical constraints. These are the main barriers we found during the focus group discussions that lead to the delayed referral practices of the healthcare provider at their health facilities. The last one is the conclusion sessions, and we found during our study period that we found they have the perceived need for the syndrome-based protocol like persistent fever syndrome. And this should be, the particular syndrome should be simple and comprehensive and need to be kept up to date as the time context up to date. And need to involve the healthcare providers during the phase of development or during the beginning of their implementation at the health facilities. And the last one is healthcare provider training should be must before the implementation of the ongoing new development clinical tools for any specific disease that need to be implemented at the healthcare providers at the health level facility. With this, I will conclude my presentation. Thank you. And the last, I will acknowledge our team, healthcare providers, NIDA Consortium, and the European Commission 7th Framework for the support of this study. Thank you very much.
Thank you, Dr. Surendra. Good primary data. And the study also has shown some important qualitative information or the qualitative feedback from the service providers themselves. Now I call upon Professor Anita Mitchell to make a presentation on the zoonotic TB in a resource-poor African community, a perceived or real risk. Professor Anita Mitchell is a professor in the Department of Veterinary Tropical Diseases at the Faculty of Veterinary Science of the University of Pretoria in South Africa. She has research interests focus on bovine tuberculosis and brucellosis and wildlife or livestock or human interface. She was the chairperson of the Scientific Organizing Committee of the ATM Colloquium in South Africa in 2011, so we look forward to her presentation.
Thank you, Dr. Kumar. A very good morning to all of you. It is my pleasure to draw your attention for a moment to zoonotic diseases research in Africa. And my presentation essentially covers two studies that we did on zoonotic tuberculosis in a poor community in South Africa. And the studies were conducted by two of my postgraduate students, Jolly Musoke and Siski Molefe, and Tangi Marcotis co-supervised one of the studies. So as an introduction, I just want to draw your attention to the long list of mycobacterium species which can cause tuberculosis in humans and or animals. And they're all collectively named the Mycobacterium tuberculosis complex. But essentially, of most importance are only two species, and that's Mycobacterium tuberculosis, the primary cause of TB in humans, and of course Mycobacterium bovis in animals, which has its primary reservoir in domestic cattle. But these species are not really specific for these hosts, but we know that Mycobacterium tuberculosis sometimes causes infections in animals, and it's a particularly serious disease and cause of death in zoo animals all around the world. And more importantly, Mycobacterium bovis, and sometimes also Mycobacterium caprae, can spill over to humans, and that is then the definition of zoonotic tuberculosis. And this occurs wherever there is direct contact between infected cattle and humans, and the disease is transmitted by aerosol, or a more frequent mode of transmission is by contaminated milk or meat and meat products. So we all know about the historical significance of zoonotic tuberculosis in previous centuries and up to the first half of the last century, before the compulsory implementation of milk pasteurization and the introduction of test and slaughter schemes for cattle. And if you've ever wondered why royalties and nobilties in previous centuries chose to wear these rather impractical high collars, then you only have to remind yourself of the clinical symptoms that cervical lymphadenitis causes in humans. And this is actually one of the main presentations of extrapulmonary tuberculosis in humans. And there was a soaring 60% of milk and dairy products that contained viable imbovis in Germany, just in the 1920s, not so long ago. So it's not surprising that up to a third of childhood TB in this country and in other European countries were due to imbovis. But that was then and there. Now, the question is, what is the situation today and elsewhere in the world? Now, the European Union reports about 130 cases per year. Latin America, a maximum of 2.5 cases out of all human TB cases. North America, less than 1%. Asia, less than 1%. So this looks like a really negligible disease. And that is what authors of this paper that was published earlier this year have also stated, that TB zoonotic TB is a negligible disease in most parts of the world, but there are some exceptions. For example, certain hotspots in Mexico, where we find a high percentage of zoonotic TB, in areas where there's a high prevalence of bovine TB in cattle, and it is linked to the consumption of fresh cheese that has been prepared from unpasteurized milk. So there we have a direct link between the disease in animals and the disease in humans. And a particular sore area is Africa. As we can see in Tanzania, up to 30% of all samples tested positive for Mycobacterium bovis in humans, and slightly lower prevalences in other African countries. I didn't list all the countries where studies were made, but they were all around about 5 to 6 or 7%. Unfortunately, we don't have any data on Southern Africa. So that prompted us to do a study to investigate the presence and risk factors with regard to zoonotic TB in a poor community which borders the TB-infected conservation area, the world-famous Kruger National Park. So here you can see a map of the area, and the center in the middle, the orange-brown, demarcates the study area. Here, the study area, and it is all surrounded by the Kruger National Park in dark green, and the lighter green and yellowish shaded areas are private game reserves, which are also part of the Kruger National Park and which are all endemically infected with bovine tuberculosis. So we actually have a very special wildlife-livestock-human interface in this area, because the wildlife is separated from the livestock and the humans by a game deterrent fence, which is most of the time very effective in this separation. But as you can see, the cattle can actually graze up to the game fence, and when natural disasters strike, like floods, then stretches of this game fence might be washed away, and African buffalo might get out into this area and mingle with cattle. They are closely related species, so they enjoy each other's company a lot. So in this study, we essentially did a prevalence study, testing 10% of the cattle population in the study area, and I'm jumping right to the results. And it was not much of a surprise that we did find M. bovis in the cattle at a very low prevalence of 0.34%. And the red circles in the map indicate the locations where we diagnosed those animals, so they were slaughtered and cultured and confirmed by culture. And the shaded area around the red circles indicate the home ranges of these cattle. So we can see in all 4 cases that the home ranges where they are allowed to graze actually border the game fence. So this prompted the hypothesis that tuberculosis could have spilled over from the wildlife into the livestock. It has never been reported in South Africa before, and in very few other countries, in fact. So to further investigate this point, we did genetic characterization of the M. bovis strain that was isolated from all 4 cattle. And as you can see here, these isolates matched the strain which is endemic in the Kruger National Park, all indicated by these green isolates, 100%. So this was the proof that exactly this strain had spilled over into livestock. In the top part of the figure, you can see a lot of different Mycobacterium bovis isolates we isolated from cattle and wildlife in different parts of South Africa. And you can see how different they are. So our second study was essentially a household questionnaire survey on risk factors for zoonotic TB. And here in the picture you can see the student conducting face-to-face household interviews with 150 cattle owners and 150 heads of household which do not own cattle. And essentially her findings were that all households owning cattle reported the consumption of unpasteurized milk. Well, that is exactly what we would expect. Of course, they consume their own milk. If we had a look at the types of milk consumed, we found that almost half the milk was consumed in raw form, so untreated. About a third was consumed as boiled milk, and 18% as the traditional sour milk. And if we have a look at the survival of M. bovis in each of these different products, obviously the survival rate is highest and best in raw milk because it's completely untreated. In boiled milk, it's probably highly negligible because as soon as you heat the milk up to 60 degrees or higher, then you kill the mycobacteria. But a problem could be in the soured milk. In a recent study that we've done, we have found that depending on the dose that is present in the milk initially, M. bovis can remain viable and can be recovered from the milk for a period of up to 2 weeks. That's actually longer than the lifespan of this product. And on top of everything else, the farmers, about a third of the farmers, sell fresh milk to the community. And when they sell fresh milk, they usually sell it as fresh milk or as soured milk, not as boiled milk. And where do the rest of the community buy their milk? Well, the survey found that about 30% of people buy their milk in the local supermarkets, which we can assume is largely pasteurized. But then there are a number of informal supermarkets, smaller shops, we call them kiosks. And they sell pasteurized as well as soured, as well as fresh milk. So sort of in equal proportions. And then milk is also sold at bus stations, taxi stations, road stalls, and pension payout points, very popular. And all these points are highly informal and they only sell fresh milk. So we can see that about half of the population in that community consume fresh milk, unpasteurized milk, or unboiled milk on a continuous basis. And largely we did an awareness study of zoonotic TB, and we found, very interestingly, that about 83% of the households that did not own cattle had no knowledge about the zoonotic impact of TB. A very high percentage. But just over 50% of cattle owners had no knowledge. So it shows us, it's very nice to see that as a veterinarian, that the veterinary services actually fulfill a very important function in educating the farmers about zoonotic risks. So what are the lessons? Certainly from study 1, we saw that endemically infected wildlife is a risk factor for M. bovis infection in neighboring livestock. And despite the existence of a national TB control scheme in South Africa, outbreaks can remain undetected for a very long time. And so what does that mean for countries that do not apply TB control measures? And if we have a look at the map of Africa, we see that all the dark-shaded countries have no national TB control program in place for cattle. There's very few countries that implement control. So that shows the immense potential risk that is there. Then study 2 showed us that unpasteurized milk constitutes definitely an important risk factor in the study area, and that the majority of the community members are actually unaware of TB as a zoonosis. So in conclusion, I want to make 2 points. Due to the presence of key risk factors relating to the source and the transmission mode of zoonotic TB, the health risk is real in the study area and probably many other areas. and therefore the potential health impact should not be underestimated. But I also want to emphasize that this is only part of the whole story. To do a full risk analysis, one also has to look at the host-specific factors. And by that I mean the human host. For example, the vulnerability of the population at risk to this disease, which may be higher because we have a very high HIV/AIDS rate, but there are also other factors which might do the contrary. And as well, the host-specific factors in the cattle, meaning the infectiousness of the cattle. We don't know, for example, whether those cattle that are reared and farmed under very extensive conditions, they don't suffer from the production stress that high production dairy cattle in Europe suffer, for example. Do they transmit to the same extent and to the same rate? In other words, is the milk really containing a high number of imbobis? So these are still open questions that need to be investigated in future. I'd like to acknowledge the Institute of Tropical Medicine and the Embassy of France for funding those projects, veterinary services of the province for their collaboration, Mariana and Jacques for their inputs, and after all, the Nisi community for their friendly collaboration. So thank you for your attention.
Thank you so much, Professor Anita Michel. To me, it seems a disastrous outbreak in the making, in waiting, coupled with the fairly high percentage of people, 46% people who consume raw milk, and coupled with the low knowledge of zoonotic TB, in the absence of a national tuberculosis control program, I fear that an outbreak is in the making in that part of the world. I am sure in our country, at least, the proportion of people who take raw milk is almost negligible. People have a universal habit of boiling the milk. In fact, we boil everything, we heat everything, we fry everything. So it applies to milk also. We never usually don't consume milk raw. So it again speaks to the cultural habits which might precipitate in some disease outbreak. Thank you so much. Now the floor is open for discussion. Any questions to any of these presenters? They're welcome.
Thank you. My name is Tanguy Marcotti. I'm a veterinarian from, I worked for the Institute of Tropical Medicine. I have a question for the first speaker about the forest disease. He said that it was a tick-borne disease. What species of tick is actually incriminated in the transmission of the virus? And I would like also to find out whether other animal species other than monkeys could be infected by this virus. Is it already known, or is it still a pending question? Thank you.
Thank you, sir. You have raised a very important issue. There are nearly 850 species of ticks are present. Out of that, this KFT virus demonstrated in 16 species of the viruses. Haemaphysalis spinocereus is the main vector which is responsible for this transmission of Kastner forest disease. And as per the mammals, in the tick life cycle, these adults, female adults lay eggs during the monsoon, and then they transform to larva, and then nymphal stage. These nymphs are very, very active, and these larvas usually feed on small mammals and like shrews, rats, rodents. Adults, they feed on monkeys, and neutralizing antibodies have been demonstrated in goats, buffaloes, wild boars, and many other animals.
Remains the monkey. Monkeys remain the predominant animal.
Thank you, sir.
Thank you very much. I have a question for the last speaker. Rounding your results, you have around 0.5% animals infected and 50% of the population consuming raw milk. Now, I was wondering, has any modeling been done to see what that means in terms of transmission, annual number of cases, or could you give just a very broad indication of the number of cases or the rate of transmission to be expected?
I did not quite get that question. Did you refer to the burden of disease that was mentioned in the publication, or which rate?
If 0.5% of your animals is infected and 50% of the population consumes raw milk, what can I then expect indeed in terms of burden of disease at population level? You said the problem is real. Yes, of course the problem is real, but is it a substantial problem? So could you quantify what it means in terms of burden of disease?
I did not say that the problem is real. I said that the risk factors are present. So the risk is real from the point of view of the source of infection. We do have the source of infection, and it's probably a source of infection that cannot be easily removed. If your source of infection is simply cattle-to-cattle transmission, and you can interrupt that cycle and slaughter out the infected cattle, you can get rid of the problem. In this case, our source is infected wildlife. That is a continuous source of infection which we cannot take away. There's nothing we can do about it. So that is the first problematic in the risk. The second one, the transmission mode in theory is present through the consumption of unpasteurized milk and the lack of awareness of the people about the risk. So their willingness to do something about it is probably negligible. I did point out that the real risk is something else, because we don't know whether it is transmitted actually from the infected cattle or not. So there's a very important component that we still need to look at. So I'm not saying the problem is there and we do have zoonotic TB in the population, but we just passed sort of the first stage to say the important risk factor in terms of source and transmission mode are there. Thank you.
My name is Vishnu Joshi. I want to ask Professor Anita Michael. The question is, what might be the control strategies to control this bovine tuberculosis? And the next one is, are the visual symptoms can we show on the bovine tuberculosis so that we can, local peoples can know to whether they consume the uninfected milk or not? So what are the control strategies to control the bovine tuberculosis from animals to human?
In one of the next steps, we obviously have to physically go to the milk that is sold in the community and to test that. So that phase is in progress at the moment. So after this has been completed, we will be able to say whether there is any viable imbovis in the milk. That was your second question. Sorry, can you repeat your first question?
So control strategies. What might be control strategies that we can implement so that the risk from transmission to bovine to human can be mitigated?
Okay, in the commercial cattle sector in South Africa, we do apply the OIE recommended method of test and slaughter. Now this is a communal livestock farming area, which means that the animals are not confined to their herds, but they're allowed to graze together with hundreds of other cattle from other owners in the same area. So the contacts are much higher. So it means testing and slaughtering is a real practical problem, and it is not feasible for veterinary services, who are also resource constrained, to fulfill that task. So at the moment we are in discussion what we can do about this to still fulfill the national mandate of TB control, but also to sort of not frustrate the farmers too much, because at the moment the area is under quarantine. So the farmers are not allowed to move any animals out of the area, but at the same time, nothing can be done to eradicate the disease from the cattle population. So it's a real practical dilemma. Thank you.
My question to Madam Anita about the same issue. According to the Mycobacterium bovis, what's the most affected part in the animals, in the cattle? Despite the main mode of transmission for the human, it is the TB is airborne disease. What is as you mentioned in your lecture, the mode of transmission is by ingestion of food, of milk, or meats. And what's the role of airborne transmission?
Thank you. The most affected parts in the bovine are the lungs. So we find the biggest lesions and most lesions in the lungs and the associated lymph nodes. So that puts people at risk that are in direct contact with the aerosols. But if you look at number of people exposed, then obviously this is a minute number. And if you have infected milk and dairy products, they will be consumed by a much larger number of people. So this is the more risky type of transmission mode. However, you need quite a high dose of M. bovis to be present in bulk milk in order to infect people. And again, then it depends on their immune status and the status of immunosuppression and so on to infect the human being. It is not known what is the dose that is required to infect the human.
I have just
we consider M. tuberculosis infection confined to the lungs. But when you really look for bacteremia, you find it. So it is actually seeding into the bloodstream periodically. If you look at people with HIV, you get bacteremia very regularly. But even non-HIV positive people with Mycobacterium MTB infection, if you repeated blood cultures, you do pick them up. So it is not surprising that it comes into the milk.
I have just a very short question about what about the impact of the BCG vaccine on this population, potential population? As we know that BCG vaccine is we main use a bovis mycobacterium.
Is also a very interesting and important question. When we look at potential control measures, in a situation like the one I have described, one would like to look at vaccination as a better control measure. However, the BCG is a live vaccine, so there are certainly concerns if people consume meat and especially associated lymph nodes of cattle that have been vaccinated. BCGiosis is a very serious disease in immunocompromised people. So if we were to pursue vaccination in affected countries, I would certainly recommend that one would have to go for a heat-killed BCG or heat-killed M. bovis strain, which has been shown to be very effective in trials in certain wildlife species in Europe, for example. So that, in my opinion, would be the way to go. Thank you.
Yes, thank you. My name is Guy Kegels. I am from the Institute of Tropical Medicine in Antwerp. When listening to the presentation given by Dr. Surendra Sur on the persistent fever syndrome in Nepal, I was not immensely surprised by the findings, but at the end, in the conclusions, what he stated was there is a perceived need for syndrome-based protocol. Okay, the question I have is this a perceived need for a syndrome-based protocol on persistent fever syndrome, or is this a call for protocols that use a syndromatic approach in general, as opposed maybe to very specific disease-centered protocols?
Thank you, sir, for questions. Yeah, there was a mistake. Actually, they perceived to need to have a syndromic approach for the diagnosis, like similar disease that arose from the fever, like malaria, tuberculosis, visceral leishmaniasis. They have to need the integrated approach to diagnose the disease in the different aspects. They perceive like that.
So do I understand correctly that this means a protocol that starts from a starting point that is called fever, and then develops this in all possible ramifications?
Yes, sir.
Thank you.
Thank you.
Thank you. I'm Bukari Abdurazak from Niger, University of Niamey. My question is to Professor Anita. We are working on similar conditions in the region named Torodi in the edge of the Park W in Niger. And we found also that consumption of raw milk is a real risk factor for the population. And my question is that we want to focus on this interface, livestock, human and animals. In your case, do you find a real case of transmission from livestock to wildlife, or from wildlife to livestock, a real case, and how that can be transmitted? Thank you very much.
Thank you for the question. It is not so easy to explain the transmission in this case where we have an effective game fence separating livestock and wildlife. It is probably a lot easier in areas where you don't have any fences separating the species, because as I mentioned, if you have infected buffalo and they can mingle with cattle, they will do so. They will share water points, and there is ample opportunity for direct disease transmission between the species. But then there is also opportunity for environmental contamination from animals that die, for example, scavengers that pick it up from them, and that will then easier go into livestock areas. We have seen this in the case of warthogs, for example, that can easily move between the game reserves. They just dig underneath a nice game fence, and they are out in a livestock area, and they scavenge whatever food they can get between the cattle, and they can contaminate food buckets and water holes and so on. We have got another species that is very efficient in transmitting diseases like bovine tuberculosis, and that's the greater kudu. That antelope, beautiful antelope, is large enough and athletic enough to jump over 6-foot fences without any problems. And they have been shown to be maintenance hosts of bovine tuberculosis, exactly like buffalo. And they even show clinical signs. They show abscesses which drain to the outside, and they do contaminate vegetation with imbovis. So there are various ways in which this transmission from wildlife to livestock can happen. It's probably delayed in a situation like ours where we have a fence, but in areas without fences, I would think that it is just a matter of time and it will happen. Thank you.
Very much. I'm afraid we have to take a break. Can I take the last question?
Yes, thank you. My name is Bart Kriel from the Institute of Tropical Medicine in Antwerp. I have a question for Dr. Kasabi on the Chiasano forest disease outbreak. If I'm not mistaken, Dr. Kasabi said he was working at taluk level, which is basically the sub-district in the Indian system, a local health system with a network of health centers and a hospital. Could he say a word or two on what has been the involvement of the taluk management team, the local yes, the local team in this event, in this disease control? How have they been involved? Could he say a word or two on this?
Involvement of
the management team
at Bandipur
in identifying the problem, possibly participating in any measures to control it.
Yes, actually this is a very interesting thing. This outbreak was identified and reported by a veterinary doctor. The Taluk Health Officer or district surveillance team, they are not aware of this outbreak before we reach there. Or otherwise the forest department, they informed the local health authorities about this disease. As this is the first time in over the 56 years of duration since 1957, this is the first time the disease was reported in Chamarajanagar district. Now they are aware. Now we have trained epidemiologists. We have epidemiologists in each district. Now we have trained epidemiologists and district surveillance team and all the medical officers and PHC medical officers in that area. We have trained them, and even our health workers are also sensitized about this Kasnur forest disease.
To add to what Dr. Gurdappa says from my side is that we have the rapid response team at the district level. But whenever there is an information regarding any outbreak in any part of the district, the sub-district health officer, who is the Taluk health officer, is taken into confidence. He becomes a member of the rapid response team. So this team goes for a full investigation of the outbreak. As far as that Taluk is considered, he is the ultimate. He looks after all the health matters, all the public health matters. So his opinion is very important. He naturally becomes a member of any outbreak investigation team. So that way, it's a mini district in itself. Thank you so much. We have had a wonderful interactive session. I have a rather pleasant announcement that we have to break for tea now.